You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, everyone, and welcome to the podcast Myelofibrosis for Medscape in Discussion. I'm your host, Tania Jain, and in the house today, we have Dr. Lindsay Rein. As you may already know, Dr. Rein is an associate professor of medicine with the Heme Malignancies and Cellular Therapy Division at Duke University School of Medicine. She's led several clinical trials as well as translational research in the scope of MPN at Duke, and we are excited to have her for the discussion today. Welcome, Dr. Rein.
Thank you. Thank you, Dr. Jain, for having me.
So our topic for today is current landscape of treatment of myelofibrosis. Just to open the discussion, humor me, if you were to envision a patient, a middle-aged 50-year-old woman who you're seeing for a new diagnosis of myelofibrosis and needs or warrants some therapy for, let's say, spleen and symptoms, how would you approach that discussion, or how do you approach that scenario, and how do you pick your medications, or how do you pick your options there?
I tend to approach therapy for patients with MF in a couple different buckets, kind of depending on symptoms or what the patient has going on. So I always approach the patient and initiate a conversation about transplant and whether that would be an option for that patient. We always incorporate a discussion about supportive cares, things that we can do as adjunctive therapies. And then I think the biggest discussion point and the mainstay of conversation is really to think about what we can do from an intervention from the perspective of JAK inhibitors, which at this moment, there are 4 approved agents for the management of patients with myelofibrosis. If we quickly go through the 4 potential options for management of patients in this particular scenario, we have ruxolitinib, which is the oldie but the goodie. So the longest standing medication that has been FDA approved for management of patients. That was followed second in line by fedratinib, another option for patients with MF and symptoms, including spleen and splenomegaly and constitutional symptoms. And then we've had the more recent approval of 2 additional agents, pacritinib for patients with thrombocytopenia, symptoms in myelofibrosis. Most recently, momelotinib, so the 4th JAK inhibitor option for these particular patients, with a specific focus on patients with myelofibrosis and anemia. To circle back to your question, if I had a patient in clinic who was a young female in her 50s presenting with myelofibrosis, and it sounds like constitutional symptoms and splenomegaly, in general, the first discussion point for me for this patient would be whether or not the patient would be a candidate for transplant. And then the second discussion point would be which JAK inhibitor I would choose for this particular patient. And so in general, for younger patients with a high symptom burden and splenomegaly, I will generally go to ruxolitinib as my first line therapeutic option.
I see. And I think that makes sense. That's probably what most of us would think about. And as you said, it may be one of the older available JAK inhibitors, but it's also something that we all feel most comfortable with and probably have the most experience with, and probably, more predictable in terms of responses and side effects, just from having a quote unquote better feel around ruxolitinib than perhaps the others. Let me challenge you there. It's not often that you get a run-of-the-mill myelofibrosis patient where the counts are excellent and you can do as you choose, right? How much does anemia bother you, and how much does that limit you or change how you approach treatment options? Let's say this patient who needs treatment for spleen or splenomegaly and constitutional symptoms and has a meaningful anemia, like around 7, or requiring transfusions every so often. Does that change how you may approach this?
So I think if we had had this discussion, say, a year or two ago, this perhaps would have been a very different conversation. But now with the recent approval of momelotinib, I think it does change how I've approached some of these patients. I think over the years, I've developed a certain comfort with ruxolitinib, but as you know, that one of the big side effects of that particular therapeutic is anemia. With the recent studies looking at momelotinib in comparison to other JAK inhibitors and other adjunctives such as danazol, I think there is definitely a role for momelotinib now in the frontline setting, in particular for patients with myelofibrosis who have a symptom burden and who are anemic. And so, in general, when patients come in and their perhaps primary cytopenia is anemia, I will definitely consider momelotinib in the frontline setting for that particular patient. I've had a good experience with the symptom benefit and the anemia benefit in a lot of those folks. And then I think the bigger question and perhaps the more challenging patient population are the patients who are both anemic and thrombocytopenic, which is something that I think we are seeing, not infrequently within the clinical setting. And for those patients, I think now, based on some more recent data looking at pacritinib from the perspective of low platelets, but also from the perspective of low hemoglobin, I think there is definitely a role in the frontline setting for some of those patients with the cytopenic MF who are more globally cytopenic.
I think that makes a lot of sense. I will say though that when I'm aiming for a transplant in a finite amount of time, like if I'm looking at transplant within the next year, let's say the high risk mutations were too prominent or the cytopenias were too prominent, does that make you think about Jakafi as a more reliable, for the lack of a better word, spleen responder than some of the newer ones, regardless of the anemia? It's a finite amount of time. Give them Jakafi, get a spleen response. If they need transfusions, kind of beef them up with transfusions. It's 3 to 4 months or 6 months. Is that an approach that you've used?
So in full disclosure, I tend to like the old school therapeutics. I have a penchant for the older interventions. And so I think if I've got a patient who I really do want to get to transplant, I'm also a huge advocate of sending patients to transplant earlier rather than later, if for nothing more than a conversation about the potential risks and to learn about the procedure. But if I've got a younger patient who is fit for transplant, and again, at the moment, this would be the only curative potential option. In those patients, I do tend to favor ruxolitinib, even if the patient has anemia. So thrombocytopenia, perhaps more of a challenging situation. For those patients, I tend to favor pacritinib or therapies where I can get full dose drug on board. But for somebody with preserved platelets and just anemia in that setting, I definitely will consider ruxolitinib.
And have you been able to use or procure luspatercept for this setting? There is some data suggesting that it may have some role in ruxolitinib-related anemia. Obviously, we await sort of the independent study results, but any thoughts about that? Is that a pro or a not so much to consider approach?
I think it's definitely a consideration. I personally have not had a lot of success in obtaining drug for this particular patient population. But I think especially with some of the recent data that's coming up the pipeline, I'm hopeful that would be potentially an easier option and a more accessible option for patients. That being said, I do tend to use a lot of additional adjunctives. So I think there is still a role, albeit probably less of a role now with the approval of momelotinib for agents such as Procrit. We certainly do have patients in clinic who have been responders to agents such as danazol, another old school intervention, and it is effective in a certain patient population. So certainly not for everybody, but if there are patients with anemia, I've definitely used that as an adjunctive therapy in combination with JAK inhibitor therapy to maximize benefit for those patients.
I do want to go back to your comment about saying that you refer patients to transplant or think about transplants fairly early. That makes me so happy and content as a transplanter. And not that I would ever doubt that. And I think I have to say that I'm seeing, even in my practice in general, I'm seeing a more sort of sense of timeliness in terms of transplant referrals for myelofibrosis, which is hopefully the trend that will stay at least until we figure out something else that is potentially curative.
I think personally for patients, when I'm meeting folks and I'm having the conversation, really the break point in my mind and what helps determine future therapies and how I approach patients is whether or not they're a candidate for transplant. So even if I've got, say, a younger patient who's lower risk, unfortunately, with these diseases, patients aren't necessarily low risk forever. And there is a finite period of time where transplant is an option. So I think from my perspective as a treating physician, it's helpful to know where the patient stands on their perspective for transplant. If they're willing to consider this as an option, or if it's something that they would never consider, that's helpful for me as I'm making treatment plans. And I think it's also really helpful for patients to have the conversation early, to learn about the process, to figure out if that's something that they would envision for their management. And so I think there's a lot of benefit to sending folks early for the transplant discussion, again, from an information perspective, and then also from a disease perspective as well.
I think that's absolutely right. I think they need to think about it. And for centers like ours, and I think yours to some extent too, who do outpatient transplants, there's certainly a component of readiness that comes with it, with the planning for transplant in terms of identifying a caregiver and figuring out where you're
Yeah.
going to stay and things like that. And I think it's important to have some lead time to plan for those things.
Well, it's a huge commitment, right? And so I think the more control you give patients to manage what they can about the disease process and their therapy, I think the more comfortable patients are moving through the entire process. And so I tend to be an advocate of early transplant referral.
Absolutely. And, the one space where transplant seems to have a more definitive role is the accelerated and the blast phase. So, share with me how you would approach someone who came in with like 11% blasts in the marrow and someone you would be thinking of transplant as consolidation, but what would you how would you get the patient to transplant where the blasts were higher than what one would usually like to see in the marrow?
So I think this is unfortunately one of the biggest unmet needs within the field. So I personally am so excited about all of the trial options that are out there. We run a lot of them at Duke, and there's so many options now for patients. The one group of patients, though, where I think I personally really struggle is these folks who are not candidates for trials or a lot of these agents because of the blast percentage, as you mentioned. So for folks like that, again, the very first thing I'll do is get them sent over to our transplant team to have the conversation, start that process. And then I think, unfortunately, the options are reasonably limited in that space. So I think a lot of times I'll consider using JAK inhibitor therapy as monotherapy if the patient has a high symptom burden, is perhaps borderline in terms of transplant status. I think there's some data out there for the use of hypomethylators, and I've certainly used those. And I think we use those as probably a standard for now in the management. And then I think for a lot of folks, what I'll try to do is use an HMA and add JAK inhibitor therapy to that in combination to try and maximize that benefit to be able to get patients to transplant. So you get that improvement in the blood counts, and then hopefully also some benefit from the perspective of the spleen as we're prepping these patients to go to transplant.
Yeah, and I agree. I think we use hypomethylating agents fairly, I guess, routinely, I would say, in this setting, especially with the data from MD Anderson that adding HMAs to JAK inhibitors can potentially, improve some of the spleen response as well, in addition to the blast reduction that you'll probably get a little more effectively with HMAs than with JAK inhibitors alone. How do you think about like AZA venetoclax or HMA venetoclax or some of the stronger induction or 7 and 3 kind of approach in these patients with more advanced disease?
So I think the reality is I've done it, and I've done it with several folks. And I think the big problem you run into is the profound and prolonged cytopenias, especially with the venetoclax based regimens. So they certainly are effective at reducing counts and creating and getting rid of blasts and clearing the marrow. I think the problem you run into is you do just that, you clear the marrow, and a lot of these patients will be at risk for infection and bleeding complications in the setting of these prolonged and persistent cytopenias. So we've done it, and I do think there's potentially a role for that if the patient is set up for transplant, is ready to go. you've had the early conversation and now the patient is in the whole transplant process. I don't use it in folks who have not yet started the whole process of getting to transplant, or for patients who would ultimately not be a candidate for that therapy.
I agree with the cytopenias from venetoclax. I think I have never done more than 14 days. And even when I prep them for venetoclax, if I'm working with someone in the community, I usually say like 7 to 14 days. And I try to stop it the day the neutrophils are zero,
Yep,
the day they
absolutely.
hit their nadir. When we tried to do longer than that in the earlier days, I think the counts they were taking forever to recover. And then as you said, then you run into issues of infections and there goes your plan for transplant. I think absolutely right. We have a nice slew of medications that are sitting in the gray zone of not approved but often used. We touched on some of them, like luspatercept and EPO agents and danazole and such. I wonder if you use or how you think about interferons in the context of, the very early myelofibrosis patients, almost prefibrotic or very early myelofibrosis, potentially sometimes even emerging from ET or PV. Do you think there's a role?
I am a huge, huge advocate for interferon therapy. I think a lot of folks don't use interferon because fear of side effect and associated profiles. I have been over the years in, treating these patients with various MPNs. I've been really, really happy with the results that I've seen with interferon. So in full disclosure, I'm pretty quick to consider use of interferon. I think there's a lot of interesting data out there now and a lot of data that's going to be coming up the pipeline supporting interferon, especially in these lower risk patients. I think we know from other MPNs, folks with ET and PV, that there's a potential for disease modification with interferon in those diseases. And if you think about MPNs really on a spectrum, which is how I tend to think of these diseases in general, right? So a disease spectrum from ET, PV, moving into MF ultimately, it makes sense biologically that interferon would potentially have a role with modification potential within these lower risk patients. So I don't necessarily use it routinely now, but I'm really excited with some of the information and data coming out to see where it will go in the future for a lot of these patients.
I haven't used it a lot in the context of full-blown myelofibrosis, but I certainly do get that question a lot. I'm like you said, I'm awaiting some of the more concrete data to be able to answer that in a more meaningful way. The next of such drugs is like IDH inhibitors, right? So again, they're available. We're still learning how or where to use that in the context of myelofibrosis. What is your approach? And obviously, in a patient with an IDH mutation, what is your approach there?
I've not used that particular intervention as of yet. I think I'm still waiting, like you said, for more concrete data to really apply those drugs. But what I'm amazed by, which is really nice, again, as somebody who's been treating these folks over the years, it's amazing to me that we now have all these options. And so I think in general, the job has become a lot more difficult recently because we're able to have these conversations and to discuss more of these agents, which we weren't able, not able to do even 5 years ago. And so that we're having this conversation, to me, is really exciting from a patient perspective.
Oh yeah, absolutely agree. And I think the the MPDRC trial of Jakafi plus IDH inhibitor will be an exciting one to look at once it's ready for the readout. In the last couple of minutes, I'm gonna I don't know, this may be a difficult one, but if you have a flow sheet or a flow chart or an algorithm in your head in as to how you summarize your approach in myelofibrosis, or a patient who you see in clinic with myelofibrosis, I'm going to have you summarize that for me and for our audience to ruminate on.
If I have a patient who comes to clinic, new consult myelofibrosis, my first break point, the first conversation we have is whether or not the patient is a candidate for transplant, depending on age, comorbidities, just a general sense. And I will actually offer a majority of patients at least a discussion with our transplant team. So for me, the first break point is simple. does the patient want to have a conversation with our transplanters? From that point on, I will typically consider the patient's symptom burden, whether or not they're symptomatic from the perspective of constitutional symptoms or splenomegaly. We will typically have a conversation about JAK inhibitor therapy and which option makes the most sense for which patients. In general, and obviously this is a little bit dependent on the patient, if patients have a lot of symptoms and a large volume of symptoms related to a large spleen, I will oftentimes consider ruxolitinib in the frontline setting. If I've got patients who are anemic only with symptoms, I will now at this point consider momelotinib versus ruxolitinib plus some type of adjunctive therapy, depending on the patient. And then if I've got a patient in clinic who has cytopenic MF, for that particular patient population, my go-to is oftentimes pacritinib, and that's really based on the platelet count, because in those patients, I would prefer to use an intervention where I can get full dose of therapy in, as opposed to having to modify doses, let's say, of ruxolitinib to meet the platelet count requirements. And then I personally am a huge advocate, especially now, of the clinical trial space. And so there are so many options out there for patients. The other caveat to my discussions with patients is, in addition to talking about transplant, now that there are so many trial options, I'll also have a conversation about what trial options are available for the patients. And I think a lot of the combination strategies now, looking at the 4 FDA-approved JAK inhibitors that we have, plus some of these novel therapeutics, is becoming a more routine part of my conversation. And I suspect that will continue as the field continues to grow.
Wonderful. Thank you, Dr. Rein. We really appreciate you taking the time. I love this opportunity to get to connect with you. And obviously, we appreciate you taking the time to educate us all about the current landscape of treatment in myelofibrosis. Thank you all for listening, and we'll see you back with our next episode next time.
Thank you for having me.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.